talking. Thanks for pointing it out. All right, so sorry. I think we are running short of time. So just welcome everyone to the second edition of our Greater Petaling City. This is focusing on the MDT management of breast cancer. And we had our first session about 2 months ago, focusing on the timely diagnosis. And for this series, we have our main hub hospital, which is our general hospital in Kuala Lumpur, as well as the spoke hospital, which is Hospital Sungai Buloh. So thank you very much for the organizer for inviting me. I am Dr. Teoh, also the chairperson and a breast oncoplastic surgeon in Medical Center KL. So without further ado, we'd just like to introduce a few panelists and also the main person today. So just a brief introduction. We have Prof. Aisha as Prof. James Brock joining us today for a brief introduction before we start our MDT session at 8:25 p.m. So this purpose of this MDT is actually to guide everyone, hopefully in the other secondary hospitals or any tertiary hospitals. All these MDTs can be held with a better management to our breast cancer. So this is also in par with the 3 pillars as recommended by the National Cancer Control Program. And we are still part of the timely diagnosis pillar. Today, we are focusing mainly on the pathology aspect of the diagnosis. So without further ado, let me introduce the first speaker, who is none other than our lead person in the City Cancer Challenge, Prof. Dr. Noor binti Muhammad Taib. And currently, she is the director in the Cancer Research Institute. And she's, as mentioned, a lead person in our project today. And she has a special interest in quality improvement projects as well as genetic screening. And currently actively involved in urban B40 barrier in cancer early diagnosis. So may we have Prof. Aisha first to introduce about this Greater Petaling City. The floor is yours, Prof.
Thank you, Dr. Teoh. So welcome again for the second installation of the ECHO program for the Greater Petaling citywide capacity strengthening of MDT management in breast cancer. So we hope that we have many participants from different disciplines today, because after all, we are trying to improve the MDT care for breast cancer in the Greater Petaling. So some introductions about the City Cancer Challenge. We have embarked on the needs assessment of 20 hospitals that in the public as well as the private sector in Greater Petaling, which is really the Greater Klang Valley, which is Selangor, Kuala Lumpur and Putrajaya. So after we have convened with the needs assessment, we will be presenting the analysis to the technical committee of the City Cancer Challenge group, as well as the City Executive Committee that is comprised of many people, not just health, but also the political and the leaders in the city. So without further ado, this program is going to carry on in the year 2023. We will be having another 4 such ECHO programs this year, and the next one will be in March with the Pantai Hospital, a private hospital that will be hosting it, and the hub hospital, Pantai Hospital, will be together with the spoke hospital, Hospital Ampang, will be presenting mainly on palliative care, because we recognize palliative care is also an important part in our part of the world. So we will be able to share with you, I think in the first installation, we mentioned that we have a best practice document on how to embark on MDTs in your hospital. That document will be shared in the next installation. So look forward to the next one, which will be on the 13th of March this year. So I think that's all from me, Ying. I think we should progress to our further agenda, the next agenda. Thank you.
Okay, thank you very much, Prof. Okay, so next up, we have our honored guest, Associate Professor Dr. Jane E. Brock. So Dr. Brock is actually a pathologist currently in Boston, and she's affiliated with the Brigham and Women's Hospital. She received a medical degree from the Royal Free Hospital and University College London Medical School, and has been in practice for more than 20 years. So she's subspecializing in anatomic pathology as well as the clinical pathology, as has various contributions to the research as well. So without further ado, I would like to call upon Dr. Brock, Professor Brock, for the next topic, and she is going to discuss with us regarding the pathological conundrum. All right, and yep, I think over to you.
Yeah. Can you hang on? Let me just check. Can you see my screen? Are you seeing me?
I think we'll need the first presenter to unshare first so that Prof. Brock can share hers.
It says I'm screen sharing right now.
Yeah, but I think
You can't see it.
No, I think Dr. Khadijah has to unshare. Yep, that's right.
Okay.
Okay.
Oh, participants can now see me. Yeah. So you can now see my first slide.
Yes, Prof.
Good. Excellent. Okay,
Thank
great.
you.
Well, wonderful. Thank you so much for inviting me to talk. I'm going to talk a little bit about cold ischemic time. Some of you may have already heard me talk about this when I was actually with you last fall. All right, let me see how I'm going to have to do this. Let's go that way. There we go. So cold ischemic time, and it's hugely important in pathology. And just to start with the definition, it's when the blood flow stops to a specimen that you're removing from a patient until that specimen is placed in formalin. And sometimes it's just a matter of seconds to minutes, and sometimes it's hours and hours and hours. I'm going to use breast as an example for all of this because I'm a breast pathologist. So when you look at the screen on the left, you see normal breast that's fixed perfectly. You can see that these are the ducts, these are the epithelial lining. This is what makes the milk in your breast. And you can see how crisp and clear those cells are. As you increase the cold ischemic time, that epithelium basically sloughs off. The cells shrink, the cytoplasm shrinks. And by the time you get to 2 days, essentially it's uninterpretable. You cannot tell what that epithelium is. And if you look at carcinomas, it's no easier. In fact, it becomes even more difficult. If you take an invasive carcinoma, as you can see in the panel on the left that was fixed, immediately the cells, the cytoplasm look great. But as the cold ischemic time increases, the cells shrivel up and they retract away from the lining, from the tissue that they're sitting in, and it becomes incredibly difficult to identify whether the cells that you see belong to an invasive carcinoma, whether they're benign ducts, whether they're in situ carcinoma, or whether they're lymphovascular invasion. And it becomes almost impossible to grade or subtype a specific tumor. They all look like invasive micropapillary carcinomas. So this is a huge challenge. This is not an uncommon problem. Even in our practice, we have this problem where we're really paying attention to the cold ischemic time. Even so, it can be very difficult. Now, that's not just the big problem. There's also a problem with biomarkers. And of course, biomarkers in breast cancer, ER and HER2, are absolutely essential to get an accurate result so you can decide on the appropriate treatment and give the patient the best chance of survival. With estrogen receptor, when it's fixed immediately, here's an example of a strong, almost 100% staining. And this very same tissue specimen with a cold ischemic time of 2 days, look how you can barely call it positive. It's gone down to less than 10% weak, and in some cases, people might not even read that as a positive. And so, you know, the decrease in expression of estrogen receptor with cold ischemic time being prolonged is really quite striking. HER2 is not very much different. An example on the left is HER2, which of course is a membrane-bound growth factor receptor that drives tumor growth. When you do an immunohistochemistry stain for it, it should be this really strong membranous staining. But if you take the same tumor a couple of days later, you've lost that crisp membranous staining. It's become cytoplasmic. You would never call that positive as a result. And so you would then have to spend extra money fishing this if you're going to do it, or many countries don't actually have the capacity to do FISH, and so you just call it HER2 negative. And so you'd have lost the opportunity to define that patient as HER2 positive. And even with FISH, you know, the quality of the signals drops off as the cold ischemic time, and you can get, again, false negatives reads with FISH when you prolong the cold ischemic time. So, of course, as probably many of you know, the optimal specimen for diagnosing breast cancer, because of this problem with cold ischemic time, is the core needle biopsy. It's rapid, it's quick, it's almost impossible not to put the specimen into formalin within, 5 or 10 minutes, at which point you have an optimally preserved tissue for your breast biomarkers and for the grading and for the and for the subtyping of your cancer. There are international standards that ask you to put your specimens into formalin within 1 hour to minimize that cold ischemic time, and a minimum fixation time of 6 hours for something like a core needle biopsy. We'll get to that in a moment, more of that. It's really hard to get this cold ischemic time under control for breast excisions and mastectomies, but it's easy for the core biopsy. And not surprising, studies have shown that you have much higher levels of ER positivity in your core needle biopsies than in your excisions, comparing the same tumor. So just a little bit about formalin fixation. Now, we always teach our residents that formalin cross-links proteins and nucleic acids, and that's how it preserves the tissue, but it only penetrates at 1 millimeter per hour. And that means that when you put a mastectomy specimen into formalin, if you haven't sliced it incredibly thickly, the cold ischemic time for that tissue will be however thick that tissue is for getting that formalin into the center of the tissue. So if you put a 10 centimeter mass of specimen into formalin, it'll take, 50 hours for it to reach the center of that specimen. And even then, it still won't reach it. Even if you leave that specimen in formalin for 2 weeks, not sectioned or not cut up, it will never fix the tissue because all of the formalin particles get used up and the proteins won't cross-link. So one of the biggest problems I see as I travel around the world is people not sectioning their gross specimens properly and putting them in a far too small a volume of formalin and thinking that if they just fix it for 2 weeks or a month, that will solve the problem. And it doesn't. It's because you've used up all of the capacity to fix the tissue. So you should always slice thinly your specimens, no matter what they are. I've got examples here of mastectomy specimens. The one on the right is a pretty standard thickness. That's about 0.5 centimeter thick. I challenged our PAs to section me a mastectomy as thinly as they could. And this was the winner here. I think these are like 1 millimeter thick, these sections in this mastectomy. But the whole point is to get it sectioned and into formalin as quickly as possible after it's resected from the patient. And another thing you can do, which is a quality metric, is to document that cold ischemic time in your gross description. We have to do this as a CAP standard for our ER and HER2 biomarker evaluation, and now we routinely do this. But you can do this, and that will help you see where you're falling short and target those locations where you're getting a long cold ischemic time. I'm probably going to run out of time to do a lot of this, so I'll just quickly breeze over this. I'm going to talk about ER and how to improve the quality of ER. ER positivity rates vary around the world. In the African population, it's around 50, Asia around 60 to 70, and Caucasians around 70 to 80%. Of course, if you treat women with early breast cancer with anti-estrogen therapy, you reduce their risk of recurrence by about 50%. But even if you treat late stage advanced breast cancer, you also reduce the mortality and you improve the patient outcome. Our threshold is set at 1%, and we report the intensity either as weak, moderate, or strong. The best thing for determining whether your ER stain has worked, your immunohistochemistry procedure has worked, is if you have internal positive control. In other words, the benign breast ducts staining. You can see here those little brown dots, those benign breast ducts staining in a sea of tumor cells. That tells you that although your tumor is ER negative, that you have that your immunostain has worked and that the tissue has been preserved well enough for the immunostain to work well. We always report, and it's a CAP standard, whether the ER internal control is present when we're reporting tumors that have 10% or less of ER expression. A little bit about on-slide positive controls. You can see an example of an on-slide positive control here. It's very good to have this. It's not trivial to set this up. You need a little bit of work in your histo lab to set up these on-slide positive controls. Great ones for ER or a high ER positive cancer, a low ER positive piece of tissue like tonsil, and then an ER negative breast cancer. A bit about HER2. Again, the rate varies. The HER2 positivity rate varies between about 15% in Europe up to 25% in Africa. Of course, HER2 targeted therapy, when added to chemotherapy in advanced disease, does reduce the risk of death and improves overall survival. Of course, it's an incredibly expensive regimen, not available to many in many countries. I'm going to skip over this. The HER2 immunohistochemistry, we give 4 different categories: 0, 1+, 2+, and 3+. I'm not going to go into that other than to say where the challenges lie. And most of the problem with HER2, when the tissue is fixed well, is overcalling it positive 3+. There's a real tendency for people who do not score HER2 routinely to overcall positive and to give you a false positive result. We should only call chicken wire strong staining positive, and you've got to be very careful which antibody clone you lose. Some of them give you a very high background staining in normal breast epithelium, which makes the tumor look positive when it's not. It should be a readily visible staining at low power objectives. So this is what we mean by chicken wire strong, this really strong, crisp, membranous staining that is the only thing that you should call positive. Here's an example of a tumor that was called HER2 positive. This is the tumor staining, and you can see it's got some membranous staining. You know, I can understand why someone called that positive, but it's an overcall. And you can see here this benign breast duct has got staining in it too. So that's a really good clue, is when you're looking at your HER2 immunohistochemistry, if you've got overstained normal breast tissue, then be very, very careful calling your HER2 3+s. Make sure that they really are this chicken wire strong and not staining like that. That's not good enough. This one in the lower panel of the 2 brown stain slides is not a HER2 positive. It was not amplified by FISH. I think this is my second to last slide, just about, and it's a little bit about the HER2 complexities for those who are interested. The threshold for calling something positive was set at 10% way back when we were doing all of the trials for HER2 therapy. It was an arbitrary cut point, but now we stick with it. About half of HER2 positive tumors have really high HER2 copy numbers, and they're the ones that are slam dunk, no-brainer, really strong membranous staining when you're doing immunohistochemistry. But about half of them have much lower levels of HER2 amplification, between 4 and 12 HER2 genes, and these are much more likely to come out as equivocal IHC staining and then needing to do FISH. Those tend to be, those lower levels of amplification also, and on the whole, tend to respond less well to HER2 targeted therapy, but that's a subject for another day. So just as an overall view, is why on earth do we care about the ER and the HER2? Well, not only do they guide the treatment options, they also tell us how long a patient is likely to survive and her predicted outcome. So, for example, if you're stage 3-4 ER positive, you still have a much better outcome at 5 years than if you're triple negative or HER2 positive stage 3-4 disease. So it's really important to get that biomarker data accurate. So my take-home messages are: the surgeons and the radiologists are actually controlling the cold ischemic time more often than not than the pathologists, and thus they control the tissue quality. So ways that we can improve this is document the cold ischemic time on your pathology requisitions and audit that cold ischemic time, and go after the reasons why you can't get it as low as possible. Come up with ways, and they can be really innovative ways, to improve your cold ischemic time for large specimens, like providing cool boxes for specimens and ice to try and get that specimen chilled if you know you can't cut down that cold ischemic time from to less than an hour from several hours. Always try to perform your breast biomarkers on the core needle biopsy specimen before deciding on treatment. That way you know that at least that the cold ischemic time will be short. And then audit pathologists your ER and HER2 positive rates, and critically evaluate the tissue histology quality and work towards improving it. And I will stop there. Thank you.
Thank you very much, Prof. Brock, for that enlightening talk. So finally, I get a picture of what is internal control. I had quite a little debate with my pathologist on that matter, actually. All right, thank you so much. I think I can see a hand being raised by Dr. Tivia. Do you want to just keep the questions to the end? Would that be okay? Or you just drop your message in the chat box, because we are going to start soon on our MDT. So we have an array of panelists that I would like to introduce to all of you. All right, so maybe we have Dr. Khadijah to share your screen, please, your presentation. So don't worry, we'll keep about 10 to 15 minutes at the end of the MDT for question and answer. So as how we conduct this MDT, this presentation will be actually led by our main surgeon from the Spoke Hospital, which is Miss Khadijah. She is actually our general surgeon in the hospital, and she has worked across, I think, in many hospitals across the country, and she has very wide experience in how to manage breast cancer as well in the MOH setting. So just a brief introduction maybe for Prof. Brock. We do have 14 states in Malaysia, and Selayang is one of them, and Kuala Lumpur is our state or capital. So Hospital Kuala Lumpur is the general hospital where actually they are the main referral center. So Hospital Sungai Buloh is one of them. And Sungai Buloh, I think, is located about 25 kilometers away from the main hospital. And they do not have breast service at this point of time, as in no breast surgeon. Okay, but everything will be managed by our general surgeon. So together with her, there's also our radiologist as well as pathologist. We have Dr. Rofiah binti Ali. She's a radiologist with 22 years of experience in her field. Going to share a bit on the imaging part of the discussion. And we do have also Dr. Salmi Abdullah on board. She's the pathologist from the Hospital Selayang. And for today's discussion, we have invited Professor Noor Kaslina. She's our pathologist from University Technology Mara, and she has more than 25 years of experience as an anatomy pathologist. Okay, for this session, our main moderator is actually Dr. Raflis, if you're around. Can we have all the videos of the panelists?
Yeah, I'm around.
Hi.
Thank you, Dr. Teoh. Hi.
Yep.
Hi, everybody.
Let me introduce you first. All right. Dr. Raflis is actually our consultant breast oncoplastic surgeon from JHKL. He graduated as a general surgeon in 2009, completed his fellowship in breast and endocrine surgery, and has been serving JHKL since 2015, I suppose, and still actively practicing and a special interest in breast reconstructive surgery. So I think maybe Dr. Raflis, do you want to introduce your team from JHKL? Briefly before we begin the MDT?
Yeah, sure. So basically what we do is we will have a case discussion first. So we have members from Sungai Buloh and UiTM hospital. So as Dr. Teoh already introduced, Dr. Khadijah will be the general surgeons, Dr. Rofiah Ali will be the radiologist, and Professor Noor Kaslina will be the pathologist from UiTM. For your information, is Sungai Buloh doesn't have any in-house pathologists, so most of the specimen will be sent either to Sungai Buloh or Selayang Hospital. That's why we invited Professor Noor Kaslina from UiTM to become one of the presenters as well. So hopefully the presentation will take about 10 to 15 minutes. Then we will discuss some of the issues related to pathologies that are highlighted in the case presentations. And then we have a further discussion on this issue. So we have expert panel as well. So I brought some of my team from Hospital Kuala Lumpur. First, I would like to introduce Dr. Vice, our oncologist. Dr. Zanaria Alias is our pathologist, and Dr. Mindy is our radiologist. So without further ado, I would like to invite Dr. Khadijah to start the presentations.
Okay. Can you hear me, everyone?
Can,
Yes.
Khadijah, continue.
Okay. All right. Good evening. Thank you for the kind introduction, Mr. Raflis and Dr. Teoh. So my name is Khadijah, and I will start off the presentation on behalf of our team, and it will be followed by Dr. Rofiah and also Prof. Noor Kaslina. So I will just, without further ado, start with the outline of the presentation. So we will first discuss a case presentation of a patient with early breast cancer, how the triple assessment was done, and the subsequent management for this patient. I will then highlight a few issues pertaining to this case and to focus more on the discordance of the IHC results for these patients between the biopsy sample and the surgical specimen IHC results. And a follow-up for this, I will also present the small audit that was done in our center of the ERPR concordance rate for all the breast cancer patients from Sungai Buloh in the year 2022. As mentioned by Mr. Raflis, that we are a hospital without an in-house histocytopathologist. So I will just summarize a few ways of how specimens are handled in our hospital before reaching the pathologist in the outsourcing hospital. So our patient is Madam AP. She is a 51-year-old Malay lady who presented to Sungai Buloh with left breast lump for the duration of 2 months. Her lump was painless and it was increasing in size for the 2 months duration. She has no nipple discharge and there's no constitutive symptoms. She gives a history of excision of a right breast lump 18 years ago, and it was benign and the event was uneventful. In terms of her risk factor for breast cancer, she has no family history of malignancy. She achieved menarche at 12 years old. She was para 3 and her first childbirth was at 23 years old, and she breastfed all her children. She denied any use of hormonal contraception. She only has hypertension and dyslipidemia and denies smoking or any alcohol intake. On examination, the breasts were symmetrical. However, there was no skin changes. There is a left nipple retraction noted. On palpation, she has a retroareolar lesion, which was about 3 × 2 centimeters. It was hard and attached to the areola, but quite mobile to the chest wall. There was no axillary lymph node palpable, and the right breast and axilla was normal. I pass it over to Dr. Rofiah for the imaging.
Okay, hi everyone. So I'm Rofiah. Thank you for inviting me. So I'm presenting the imaging part of the for Madam AP. Go on, Khadijah. Okay, this is her bilateral mammogram CC view done on the 1st of July last year. So in this mammogram, we can see a symmetric density in central left breast. With suspicious polymorphic calcification. Maybe you can't appreciate much because the resolution is not good. And then also there is associated thickening with nipple retraction of the left breast. And on the right side, there is a cross calcification in upper inner quadrant of the right breast, is suggestive of benign lesion. Next. Okay, in MLO view, okay, not that obvious. Only the obvious thing is asymmetric density of the mid left breast with associated skin thickening of the overlying skin. Next. Okay, then we proceed with ultrasound left breast and bilateral breast. So for the left breast, there is dilated retroareolar and paraareolar ducts with multiple retroareolar intraductal lesions, which is hypoechoic, and also can see microcalcification in the ducts, and with diffuse skin thickening and also enlarged axillary lymph nodes with thickened cortex. So next. On the right breast, there's a well-defined hypoechoic nodule with cross calcification, suggestive of a benign lesion. Next. So on another finding there is like axilla and large lymph nodes is and seen in ultrasound. So next. So in summary, there are suspicious left breast pleomorphic calcification with ductal dilatation and retroareolar intraductal lesions, as well as bilateral axillary lymphadenopathy. Then this gives us ACR virus 5. Whereas on the left side, on the right side, there's benign lesion. This is ACR virus 2. So we recommend for ultrasound guided biopsy of the left intraductal lesions. So ultrasound guided biopsy is done about a week later. During revision rescanning of the patients before proceed to ultrasound guided biopsy, the radiologist found another lesion at the 12 o'clock 2 cm from the nipple. So she biopsied both lesions, retroareolar intraductal nodule, and also the nodule at the 12 o'clock. Next. Okay, then CT staging was done on 2nd of September 2022. This is done after surgery. For information of all, usually in Sungai Buloh Hospital, we managed to do CT staging prior to surgery. However, at that time, unluckily, there is a replacement of our CT scan in main department. So one of the CT scan is not work, cannot be used. So that's why the CT scan was done after the staging was done after the surgery. So the positive findings only bilateral axilla and large lymph nodes, and no evidence of distal metastasis of the patient. Okay, I think that's all from radiology. Thank you.
All right. Okay. So following the ultrasound guided TrueCut, the HPE came back as infiltrating carcinoma with a high grade DCIS component. The immunohistochemistry revealed that it was estrogen receptor negative, progesterone receptor negative, and HER2 positive. So in summary, this patient, he is a 51 years old Malay lady who is para-3 premenopausal with hypertension and dyslipidemia, presented with left breast lump for 2 months, painless and increasing in size. And on examination, found to have left nipple retraction with a hard retroareolar lesion about 3 times 2 cm. The mammogram ultrasound, there's a BRATS 5 lesion with bilateral axillary lymph node, and TrueCut biopsy has confirmed invasive carcinoma with a subtype of HER2 overexpressed. So the clinical staging for this patient is CT2N1MX. The patient had upfront surgery on the 15th of August, left mastectomy and axillary dissection. The intraoperative findings was left breast purely orange. The lesion was about 2 centimeters, and there were multiple and large right axillary lymph nodes. I will then pass over, so the mastectomy HPE, in summary, it was a solitary retroareolar lesion, and there was about 11 positive lymph nodes. The estrogen receptor was positive, and the progesterone receptor was positive, and the HER2 was equivocal. The pathologic classification was PT3PN3A. I will now pass over to Prof. Kaslina to describe more about the histopathological examination of both the biopsy specimen and also the surgical specimen. Prof?
Okay, thank you very much. Thank you for inviting me. So I will present on the tissue biopsy that was sent in July. So we received 2 specimens which label as left 12 o'clock and as well as the retroareolar lesion. So this is the representative of the tissue biopsy, which as you can see, there is clusters or sheets of the malignant epithelial cell that infiltrating the the area whereby you can't see any native breast tissue. So basically we have a strips. The first one is about 3 strips and the other one also 3 strips. So both are containing specimen containing the solid sheets of the malignant epithelial cells. Can I have next slide? This is just to show the higher power. As you can see just now by Prof, that showing how the tissue that well preserved looks like. You still can appreciate the nucleus and the cellular outline, which is the cytoplasm. Here you can see slightly eosinophilic, but they can show the pleomorphic and hyperchromatic of the nuclei of the malignant cells. Next slide, please. This is another area that's showing whereby these malignant cells also infiltrated to the adjacent fatty tissue, which included in the tissue biopsy. You can see clearly now is a better, can be appreciate view of the mitotic figures and the pleomorphic and hyperchromatic of the malignant nucleus. Next slide, please. Okay, this is the ER and PR immunostaining stain for the tissue biopsy that we received on the 8th of July. As you can see, none of the nucleus, by right, the ER and PR should take up the nucleus of malignant cells. But you see on the left side is the ER and on the right side is the image for the PR, immunohistochemistry. None of the cell has taken up staining with the brown staining of the nucleus. Next slide, please. Okay, this just to show and the immunohistochemistry for the COP2 or HER2 on the tissue biopsy that we received on the 8th of July. As you can see, there is well outlined the cellular membrane, very dark browns here. So this is we report as a 3+ for the HER2 immunohistochemistry. Next slide, please. Okay, this is just a representative section that taken from the mastectomy specimen that we received on the 16th of August. You can still appreciate that the malignant cells that infiltrate into this tissue with very markedly pleomorphic nucleus and hyperchromatic, and appreciate that numbers of the mitosis can be seen as well here. Next slide, please. Okay, this is a mastectomy specimen that has been stained for the estrogen receptor, which you can appreciate that the nucleus staining with brownish in color. So this is, we report it as ER positivity in about 70 to 80% of the tumor cells. Next slide, please. This is sustaining for the immunohistochemical chemistry for progesterone receptor on the mastectomy specimen. As you can see, not all the tumor tissue has stained with the dark, a brownish in color. So this one we estimated around 10% of the tumor cell that shows the positivity on immunohistochemistry with the progesterone receptor. Next slide, please. So this is what we RHC for the as you can see, the staining was not circumscribed the entire tumor cells. So they are weak to moderate staining to see That's all, Khadijah. Thank you so much.
Thank you, Prof.
Therefore, the staining was put up as a 2+ equivocal. That's all from me.
Okay, thank you, Prof. Okay, so as mentioned earlier, we are a center with no in-house pathologists. So I'm just going to explain how the specimens are handled in our hospital before it reaches the histocytopathologist at the outsourcing hospital. So the fixation of specimen is as per the general protocol. So as soon as the specimens are obtained, they are put in formalin and as soon as possible to reduce the cold ischemic time. The specimens are then packed and sent and ordered, processed and ordered via the computer system, and the location where it goes, because there are several hospitals who accept our specimens, and these are determined during the processing in the computer. So once the location for it to go has been decided, has been confirmed, and stickers are printed, the specimens are labeled, they are sent to our pathology lab first, where it will be kept there in room temperature until the transportation to the receiving hospital. So the transfer to the outsourced location happens the following working day at 8 o'clock in the morning. So if the specimen was obtained on a Friday, so the specimen will be kept here in Sungai Buloh for longer. That means the next transport out will be the following Monday at 8 o'clock in the morning. So I can foresee some problem happening when we have long weekends. Recently, we had a 4-day weekend where it was a Saturday, Sunday, Monday, Tuesday, public holiday. So that means the specimen would have been kept in our hospital for 4 days, and the following transport will be on the Wednesday morning to the outsourcing hospital. So the location for outsource, so we have about 4 centers who accept our specimens. The big specimens, especially colon and breast, goes to hospital UiTM, which is the closest among the 4 hospitals, and other organs goes to hospital Selayang. Biopsies of any parts of the body goes to hospital UiTM. The stomatology samples goes to the National Institute of Health, and brain specimens are sent to Hospital Kuala Lumpur. So just a little audit that I said about that we did on the ER/PR concordance rate for our breast cancer patients in 2022. The total number of cases operated by surgeons in Sungai Buloh cumulatively is 49 patients. From this number, we excluded 5 patients from the analysis, as the IHC was not repeated on the surgical specimen. So only the pre-op biopsies, IHCs were available. So for the estrogen receptors, about 6 cases out of the 44 were discordant. So in 4 cases, the initial CNB's core needle biopsy was positive, and the surgical specimen was negative. And the other 2 cases, the core needle biopsy estrogen receptor was negative, but the surgical specimen turned out to be positive. So the total concordance rate for estrogen receptor was 86%. For progesterone receptor, only 2 cases out of the 44 were discordant. 1 case each for a positive core needle biopsy with a negative surgical specimen, and a negative core needle biopsy and a positive surgical specimen. The concordance rate for progesterone receptor was 95.5%. So sorry, some of you might wonder why we only do 49 patients in 2022. So just Prof Jane, that we were half of the year last year we were a fully COVID hospital, the only one in the Klang Valley was fully COVID. So we did not do much of elective surgeries in the first 6 months of the year. Okay, so just going back to the issues pertaining to this case, so the main one that we wanted to discuss was this discordance between the pre-op and the post-op. So as we all know, the initial immunohistochemistry from the core needle biopsy impacts greatly on our decision for the initial treatment for the patient. mainly to decide on the indication for new adjuvant therapy. And furthermore, the latest evidence and the most recent guidelines has established the benefits of new adjuvant therapy even in early breast cancer patients. So in select cases of triple negative and HER2 overexpressed patients. So which brings us to the issue of that our center has no in-house histopathologist. So whether the prolonged fixation time to accommodate for all this, the additional time for the transportation, waiting for the transportation to the outsourcing hospital, whether this contributes to further tissue degrading and therefore results in loss of the IHC antigenicity, whether this is something that we have to concentrate on or not. So the other issues that was discussed earlier by Dr. Rofiah was the delay in the CT staging. This is most resource issues. And some of you might wonder why this patient was HER2 overexpressed early breast cancer, was not subjected for new adjuvant therapy to begin with and had upfront surgery. So as I mentioned that this latest evidence came up and at the time where the patient presented to us, she was still managed as per the old guidelines. So she wasn't sent for a new adjuvant and she had upfront surgery. So I think that with all those issues highlighted, I end my part of the presentation and I give it back to you, Dr. Raflis.
Thanks, Khadijah, for the presentations. So before we jump into the issues about the discordance about the IHC staining between the core needle biopsy and the surgical specimens, I got a few questions from Dr. Khadijah. One is whether is there documentation about when was the surgical removed and when is the tissue put in the formalin so that we can estimate the ischemic time. And the second thing is the issue that you brought up is over the weekend where the specimen will be kept in the Sungai Buloh for at least 2 or 3 days before it's sent to the UiTM. Is there any measures taken to improve the physician, like who did the slicing, whether the slicing done by the pathological lab or was it done by the surgical team?
Okay, thank you, Dr. Raflis. Yes, there is documentation by the nurses who received the specimen in OT, what time the specimen was taken out from the patient and what time the specimen was put into formalin. As for the second question, we surgeons, we don't practice slicing the specimens. So when the specimens come out, we straight away hand it over to the scrub nurses for packaging into formalin. And when I queried with our pathologist in the lab, they also do not touch the specimen. So the specimen are kept as it was removed from the patient's body the whole time it's in the lab.
Right. So can I have some input from Dr. Kaslina? Is there what was the protocol to improve or to address this issue? Whether the slicing should be done in Sungai Buloh or is it mainly performed in the UiTM?
Okay, personally, I would like to slice by myself because sometimes we worried that whatever the nature of the lesion might be distorted after we are the first to have a look at the specimen. So I would rather to do by myself. I think it shouldn't be issue because the Hospital Sungai Buloh and UiTM Sungai Buloh is quite nearby, and I'm sure that because this one on the mastectomy specimen was done on the 15th of August, right? So we received the specimen very early in morning on the 16th of August, and I'm sure that it's quite usual for the specimen that we receive on the day after the operation And of course, the slices, always we are doing the slices of the specimen. If the specimen is huge, need to be fixed properly before the section is being taken for the microscopic examination.
So, Prof, yeah, this situation also applied to a situation where you have a long weekends, like the surgery is done in Fridays. Is it still apply like that? Because if it's done on Fridays, then the specimen will be sent on Monday, right, in the morning. So do you think there will be issues in the pathological reporting?
For us, if we receive on the Friday afternoon, before we go, we still slice the specimen. That is what we receive on the Friday. They say around 2 p.m. or 3 p.m. we still do the slicing before 5 o'clock. But if after that we don't receive specimen after office hours on Friday, that is for the UiTM. Maybe Dr. Salmi can give your comment on this.
Okay, Dr. Salmi, you're around? Okay, just a quick introduction. Dr. Salmi is one of these pathologists in Selayang. So she's also sometimes handling tissue from UiTM as well.
Not sometimes, we are the center actually. Yeah. I think the problem here is we are not talking. Actually, the surgeon and the pathologist. That is my view here. Yeah. In MOH setting, actually, Sungai Buloh Hospital is basically covered by histopathologists in hospital Selayang. Okay. And some of the specimen, yes, it will go directly to Hospital Kuala Lumpur, especially the brain cases, because the neuropathologist is in Hospital Kuala Lumpur, and the neuropathologist, especially for epilepsy cases, they prefer to receive the gross specimens. Yeah, and in MOH setting, as I mentioned, Selayang is covered by Sungai Buloh, but some of the specimen will go to UiTM pathology site. Yeah. And I'm not sure how the laboratory decide on which specimen goes to Sungai Buloh and which specimen goes to Hospital Selayang. Because as far as I'm concerned, the consensus was before this, the big specimen or the surgical specimen will come to us in Selayang, and the biopsy will covered by our UiTM colleague. Yeah, and I hope from now on, yes, we can improve this situation in maintaining the credibility of our results. Yeah, I think we should have a meeting after this. Yeah, but from the presentation from Professor Brock, and I hope our clinical colleague, our surgical colleague do understand that the ischemic control time is actually starts from the surgeons, i.e. from the OT. Yeah, and I think for this case, there's no point for us to pinpoint where the things causing the discrepancy in ERPR in HER2. Yeah, I think for the future we should meet and really discuss about handling these specimens in terms of who should handle the specimen or who should cut the specimen. We can discuss further. I don't mind if the surgical side do the slicing, but yes, I think it should be done as to maintain the architecture, as to maintain the anatomy of the tumor, so that there is no discrepancy in terms of measuring the tumor and all for us, the pathologist. That one is quite important. I think that is what is meant by Professor Dr. Kaslina just now. And I hope in the future the surgeon will put the ischemic time that was stated, I think, in your OT notes in the our histopathology request form. That would be important. I think in the future that is one of the factors that will be audited. Yeah. Is it okay? Yeah, I think that is my feedback for this case.
Thanks, Dr. Salmi. So just to share HKL experience, maybe Dr. Zanaria also can give some input. For slicing the specimen, we normally don't do as well in HKL, but the issue is arise when there is a long weekend.
Dr.
So
Mr. Rafi.
So what normally we now agreed that in HKL, whenever there's a long weekend, the surgical team will do the slicing, so that will help in the fixation of the tissues.
I guess the slicing is just like only by valve the tumor, something like that. It's not like
Yes,
a 1
yes.
mm slicing for the entire mastectomy specimen.
It
Yes.
depends on the size of the specimen. So if the specimen is big, the tumors are big, normally we will do like 2 or 3 cut as well. Maybe
Depends on the
Dr.
size of the
Zarinia has some input as well on this.
Assalamualaikum. Okay, for HKL, okay, because I'm posted in HKL. So we have for the long weekends for the surgeons, Mr. Raflis and others, you have to know that when, for example, like on Friday, once we receive the samples, which is probably late afternoon, we will slice on the same day. So whatever we receive on the same day, we will slice, and the next day, then we will do the cut up when it is fixed. Okay, what happens sometimes? Beside we are talking about the time when the specimen entered to the formalins, and when it goes to the lab and got to be sliced, further slicing. To, let's say, it's about 10 mm in thickness, and we change the formalin concentrations and put in the appropriate container. The other thing is actually we have also to look on the concentrations of the formalins in the surgery. Sometimes we have issue previously where there's these concentrations of formalins is not as good and not as what we have in the lab. So what happened is that the specimen is not really well fixed, although and that is the cause of this prolonged these changes of cold ischemic changes. So we also have you have to test to ensure that the quality of your formalins in the lab, in the OT that you're taking from your pharmacist is in a good or a quality concentrations. Then if about here in HKL, once we, although there is a long weekend, we always there is always someone there is a rotations for the medical officers to come on Saturdays or Sunday to do the slicings, and sometimes we continue the section taking the samples or from the previous day or from the previous day specimen. So it's actually we are not stop the lab doing the processing during the long weekends. We still continue, although there is a long weekend. So I have to ensure that specimens in somewhere, a quite busy lab, we still continue it, although it's a long weekend. So that should not be, or we have sometimes taking that we have reduced these sampling errors. And then I have also to tell you about what is the situations, why actually the historical, why Hospital Sungai Buloh doesn't have anatomic pathology. So this is back to the 2005, where there is 3 hospitals, new hospital coming up at the same time. So at that time, we have only about let's say less than 100 or less than 50 anatomic pathology for the whole country. So we have about 10 people in the Lembah Kelang. So we thought of a centralized anatomic pathology service would be better, so that we can accommodate a bigger area at that times. So for that, we have decided the ministries, because I'm also the head of anatomic pathology disciplines for Ministry of Health in Malaysia. So we decide at that time to concentrate, to have the to make that Sungai Buloh, since the initial decisions to be infectious disease hospitals. So we decide that for Sungai Buloh, it will cover to Hospital Selayang, which is about 10 kilometers from the 10 to 15 kilometers from Hospital Sungai Buloh. At that time, there is no decisions that it will be covered by UiTM. UiTM faculties coming later. So, and hospital also that Hospital Ampang being covered by Hospital Sedang, because that is the in the same state. Okay, so HKL, we are the the tertiary center. We have all the disciplines for under surgery, that including breast, endocrine, neuro, nephro, and others lah, for that we process for for anatomic pathology. So we covered, let's say you say all the neuro cases we are covered by HKL, because we have a neuropathologist here. In for breast, is actually can be read or can be report by other general pathologists. But now we have a pathologist that have the area of interest in breast and endocrine. So there is a few centers that have this specialized pathologists interest in breast and endocrine. So I think, like Dr. Salmi have mentioned, is more towards that we need to talk, have discussions to solve this issue of if there is an issues of delayed in term processing, or delayed in handling the specimens, or delayed in reporting, or there is discrepancies in terms of the outcome of either the reports or the tests done to the specimens. Okay, Mr. Raflis, I think for HCAS, yes, we have all the, but at this time moment, I can say our futures, yes, we can change this concept of centralized, and we can go back to the decentralized. That's mean we can put anatomic pathology in Hospital Sungai Buloh. However, we have to say that it's not just human resource that we have to put there. We have also to build up the lab itself, where the lab requires other support technical staff, as well as equipment, as well as space to put all these equipments processing for the tissue. So that is actually, for your information, is in our future plan. In our K-12, we have decided that to have it. However, it depends on the money or the allocations that agreed by coming from the ministry. So it's actually, for your information, we have a thought to open an anatomic pathology service in Sungai Buloh, but it's not exactly in this 1 year or 2 years time, because we need to find an area for the lab to be built, and then we can come up with the pathologist. Because if you don't have, we just have the anatomic pathologist but doesn't have the lab, also is not great helpful.
Okay, thank you.
And at the
thank
same
you,
time, we have also the UiTM nearby. So that is why we make use to have that functions. UiTM is close by to Sungai Buloh.
Yeah, we are
Thanks.
grateful to our UiTM colleague. And
Yes,
Thanks, Dr. Zanaria.
I
Maybe
couldn't
can I
agree
have
more with
some
Dr. Zanaria.
input from Dr. Jane Brooks about this situation? Is it common to encounter in your countries? Or
Yeah, absolutely. Yeah,
do you have any
we have
suggestion
huge
for us?
problems. Yeah, we have huge problems with cold ischemic time, exactly the way you do. And I did notice on that specimen that in the case that on the excision, the hang on, let me see. It's always oh no, I can't show my video. Sorry, you'll just have to listen to me. It's a huge problem, and you just have to work at it. We have, you know, it's actually kind of not okay to let the specimen go, you know, 2 days without slicing it, and it's really uncomfortable to ask your surgeon as a pathologist to slice the specimen. I know that, you know, you feel like you own the specimen and you don't want you don't want someone else to touch it, and I completely understand that. But the reality is that you actually have to let go of it a little bit. You know, you can watch your surgeon slice it and you can tell them, no, you're doing it wrong. And, you know, obviously you want to slice it from the posterior margin towards the skin surface and leave, you know, about a ½ centimeter intact in the skin so that you don't lose the integrity of the specimen. But by all means, I would actually, in your situation where you have to transfer the specimen, where you've got cold ischemic times of at least a day, and I could tell from that excision specimen that you had a cold ischemic time of at least a day on that. That was why the HER2 went from 3+ to 2+. It's kind of obvious, you know, as to why the ER went from negative to positive. There was a blush of staining on that core needle biopsy. I would say, you know, that was probably due to heterogeneity in a HER2 positive cancer. You know, some of the HER2 positive cancers can have very heterogeneous ER expression that falls, you know, outside the greater than 95% or less than 10%. So obviously that was one of those tumors. But, you know, I don't see why you can't train your surgeons to do the sectioning as you would want it. You know, you're not usually dealing with 1 centimeter tumors. You know, you're dealing with big tumors most of the time, such that you know, it's not, you know, they're not going to destroy the specimen, you know, provided you can, you know, as a pathologist, you can keep a close eye on your your surgeons.
Yeah, agree with you, Dr. Jane. Yeah, we surgeon can do it. No problem. Okay.
I mean, I understand that we as pathologists get very possessive. We're very jealously guard our specimens, but at this point, you know, you just have to give it up, and you know, in the interest of cold ischemic time.
Yes, I think sometimes what happened is that the specimen got distorted when they are not properly packed, you see. So it's very difficult for us when we do sampling. But I agree with Prof. Jane, we can actually teach the surgeon how to slice the specimen properly.
Yeah, we will teach Khadijah.
Yes, we're open to anything. I mean, I'm sure splicing the specimen is not as difficult as doing the mastectomy.
No. I'm sure it's not as difficult as doing the surgery. You just need to do it in the right orientation. Yeah, that's you just need to do it in the right orientation. And you know, you can have some black ink. You can ink the deep margin. It's trivial to ink the deep margin and mop it, and you know, and then slice it.
I think that's a bit too much.
It's not. Yeah, it just takes a little bit of training, and that'll be so much better than risking the specimen going 24 hours or even, you know, over a whole weekend without being sectioned. The other thing I would point out is look at your volume of formalin that you're using and the containers that you're putting it into. You know, the volume of formalin should be, you know, at least 5 times more than the specimen volume. So in other words, you know, if you're squashing that specimen into a small container and then topping it up with formalin and thinking you've done a good job, even if you've sliced it, it won't fix, right? You need a lot of more formalin than you think you do to fix that tissue.
Sure.
Okay, thank you, Dr. Jane. Just one last more question, because I think we are short of time. Maybe Dr. Ruzairee or Dr. Kaslina can just highlight some issues that may explain why there's a discordance between the IHD staining between the core needle biopsy and the surgical specimen.
Yeah, I think I agree with the Prof. Jane just now. There is some heterogeneity of the receptor that present on the tumor cells. Probably the core biopsy, you know, whatever the tissue or the malignant cell that has been taken for the biopsy at that time has no receptor, so therefore the cell is not picking up the stain. However, in the mastectomy specimen, the area that I taken for the sections to be bigger. Therefore, as you can see, the staining not 100%, it's about 70 to 80% for the ER, and the PR is about 10%, which is a very, very, I would say is a very few. Therefore, in the small tissue, probably whatever the cell has been taken up does not have the PR or ER receptor.
Okay, any comment from Dr. Zanaria?
I think yeah, the tumor histogenicity is actually one of the issues lah. I think if you see about the fixations, delayed fixations of the what is that, the biopsy, the biopsy specimens as compared to the specimen. But when we see the slides, I think there is some changes of the ischemic changes, but it's more inside the biggest specimen rather than the biopsy. So usually biopsy there is another thing that I have to tell you about checking the qualities of your formalins in the OT. Other than that, because this is not the other way around. Then I have also to tell you, because this is our practice now. If we have the negative biopsy, we definitely do as a reflex test. We will repeat in the bigger specimens. That is already instructions to all the pathologists, anatomic pathologists, to all the obstetricians to repeat the IHC stains, ERPR stains in the biggest in the mastectomy specimens.
Okay, thank you, Dr. Zanaria. Teoh, I think I pass the mic to you. I think we have supposed to have 15 minutes Q&A. Now we only have 5 minutes. So yeah.
Yes, thank you very much, Mr. Raflis, and thank you, dear panelists and presenters, for a very interesting discussion. And actually, I've learned quite a lot from this, not knowing what is the correct fixation time to knowing it now. Okay, actually, we do have a couple of minutes more, probably about 5 minutes. I'm just going to open this to the audience. So any burning questions from the audience? Please don't be shy in asking questions. If you're shy, we have the chat box ready for you to just type in the question. All right. Okay, so yeah. Yes.
I think while waiting, maybe we should really summarize what we've learned today, because I think some of the audience are not pathologists. Some may actually be medical officers or general surgeons out there practicing in different parts of the country. So number one, I think the main question is, should we repeat the biomarkers? So I think we heard Dr. Zanaria saying that there is a directive to repeat. Maybe we can also ask Dr. Jane, what would be the practice in the US? Because I think staining means you are actually spending a lot of money because you're actually repeating the immunohistochemistry. So what would be the practice in the States when it comes to biomarkers? Are the core biopsies taken as it is? Or there is a question from Dr. Vaish in the chat box. In which instance should we do the repeat immunohistochemistry?
Yeah, I put that answer in the chat already. When you're ER negative on a core needle biopsy, when it comes to the excision specimen, repeating it is recommended. When you're HER2, if you have a positive result, you don't need to repeat it. That's basically it. If you have a negative HER2 result on your core needle biopsy and it's a well-differentiated tumor, or something that's just not likely to be HER2 positive, there's no real reason to repeat it on the excision. If you have a sort of a moderately to poorly differentiated ductal carcinoma on your core biopsy and it was HER2 negative and you only had 3 or 4 millimeters of invasive cancer on your core, but you've got this 3 or 4 centimeter cancer on the excision, you could repeat the HER2. But again, you've got that problem. If you know that your cold ischemic time is getting up over 24 hours, you're going to get nothing other than an equivocal result and have to fish it. So it's,
we're learning a lot from this opportunity.
Sorry. Yeah. So generally, you know, you use your common sense when repeating it. You know, certainly do not waste money. And if you simply don't have the money to repeat it on the excision, then, you know, that's fine. You can trust, you know, you have to, at some point, you have to trust your core needle biopsy. You have to trust the results that you get. So, you know, I would be fine, you know, with limited resources, only doing it on the core needle biopsy and not looking again for HER2 positivity. Because if you've got limited resources, you can't afford the HER2, you know, targeted therapy anyway. So.
Okay. Right. So
yes,
go ahead, Prof.
I'm just answering a question in the chat now about specimen handling in the ORs. So in our ORs, we have fridges outside every OR. Every, you know, little pod of 4 or 5 ORs each has a fridge, and so as soon as that specimen comes off the table and is logged, it goes straight into the fridge, and it sits there in the fridge until it's collected by our pathology technicians, who then transport it to our pathology room, and then it also goes back in the fridge up in our pathology room. Actually, that's not true. We now actually take it straight to our frozen section room, and we section it to get our cold ischemic time under an hour. But before we did that, we were basically getting that thing in the fridge immediately and keeping it in the fridge until we could section it. So, you know, that worked for us, but it actually still gave us a prolonged cold ischemic time that was a problem for us, and so that's why we changed our policy. But I absolutely understand it's really, really hard to get that cold ischemic time under an hour, but there are ways you can mitigate the tissue degradation, and certainly putting the specimen in the fridge will not cause ice particles to form unless you're freezing it, which I don't recommend. But if you're putting it in a cold fridge, that will really help slow it down, but it doesn't solve the problem. It certainly slows it down.
It's in formalin, Prof?
No, because our surgeons and our nursing staff don't have access to enough formalin to put a whole specimen in. But we're lucky, you see, it's all in the same hospital, and we actually use our pathology technicians to go around the ORs and collect the specimens every couple of hours. They go and collect the specimens. And our breast specimens specifically, we actually get our OR nurses to bring them to our frozen section room where they're handled immediately. They're immediately grossed, you know, an initial quick gross, sectioned and put into formalin, so that we get our cold ischemic time under an hour. And even then, we struggle to get it under an hour because, you know, our frozen section room can be incredibly busy. And so you know, that's what you just have to keep trying, right? You just have to keep trying. And we ordered our cold ischemic time, and we beat on the surgeons who seem to have a cold ischemic time that's longer than everyone else's, and say, hey, you're falling a little bit short of your colleagues, which is a bit harsh, but it, you know, it does the trick.
Okay. All right. Okay. Thank you, Prof.
Right, you keep an audit in the hospital of the cold ischemic time, and there's like a audit report. Like, is it a monthly thing? Or
I actually have to go and look at them. It's kind of frustrating. I have to go and actually pull it from our pathology reports. Yeah.
Yeah.
Okay, I think it's very, very pragmatic, isn't it? How we need to solve this, because a whole mastectomy specimen is going into a big jar. Like, I know some hospitals use those big cookie plastic jars, you know, that we use for our festivities, the 2-liter bottles, which I think is a lot of money.
We still do that, Prof. Yeah.
Mm-hmm. Yeah. So I think costs money. So I think it's nice to also hear from the oncologists here. I think we have Dr. Vaish and then also Dr. Mindy, radiologist from HKL. Any comments? Because I'm sure you do a lot of biopsies in the radiology department, and Dr. Vaish, you might have some issues or some questions.
Yeah. Dr. Mindy, you want to start first? Yeah.
Hi. Actually, yeah, we our biopsies are done on the beginning of the week, so we do it in the morning. By afternoons, all our specimens are usually collected. And is there anything that you would suggest, Dr. Brock, for the radiology point of view for our biopsies?
Are your you're talking core needle biopsies? Are you?
We're doing core needle.
Right. Well, are you putting them straight into formalin within 15 minutes of them coming out?
Yes.
Yeah. Then you're doing a great job. I mean, so long as
after.
so long as your formalin is good quality formalin, 10% neutral buffered formalin, then, I suspect that your corneal biopsies are superb for cold ischemic time. The only time we have problems with our corneal biopsies, and we do have them, is when our radiologists stuff the cassettes because we actually get our radiologists to sort our cores out, and they'll actually wrap them in lens paper for us so that we don't want any cross-contamination between patients, like mixing up cores or anything like that. And so they have a bit of a habit of putting, big cores, lots of cores all in one cassette, whereas you want to sort of divide them between two cassettes. You don't want sort of eight very fat cores, in one cassette, because then they don't fix very well in our processes, because we have different processors times for different types of specimens. So that's our problem, is actually fatty breast cores don't always fix and process well. And so long as you're not doing that, or you're aware of that and don't do that, then I don't think you'll have a problem.
But no, we don't practice that. Thank you. Off to you, the Vaishnavi.
Yeah, I mean, of course, as an oncologist, we get very troubled when the ER/PR or HER2 doesn't seem very consistent, mainly because I think we are all very aware how the treatment paradigm now has shifted so tremendously. Actually, I want to take this opportunity to thank Dr. Salmi. I know she was tremendous in coming forward with the implementation of ER/PR HER2 testing on initial biopsy. Of course, we did struggle a little bit initially to try to get our Ministry of Health centers to do ER/PR HER2 on initial biopsy. Of course, once in a while, we do still see some specimens not being biopsied with the ER/PR HER2, but nevertheless, I think there's been a tremendous improvement. Would really like to comment on Sungai Buloh having taken up this whole change in the way HER2 positive and triple negative breast cancer operable patients are being treated. And I think with Dr. Maninder's support the last time, we managed to get quite a few radiologists from 7 different hospitals to be trained with breast clip insertions. Hence, this whole teamwork with regards to giving neoadjuvant therapy for HER2 positive patients and triple negatives to have treatment prior to surgery. So just a little bit of a comment from an oncology point of view. I think most of you would be aware in triple negative disease, the chemotherapy which used to be given after surgery is now given prior. So there's no issues with access, there's no issues with cost, there's no issues with anything. We just need the surgeons to help us get the biopsies and refer them if the tumor is more than 2 centimeters or the axillary nodes are positive. Point number 2, with regards to HER2 positive patients, if the HER2 positive is documented, in our government formulary now, Herceptin has been approved as a formulary indication for neoadjuvant therapy. So of course, in the past, we struggled a bit with getting Herceptin for patients in the neoadjuvant setting. So that is a little bit of an improvement that we have seen. But majority of our patients actually do get doublets, which are pertuzumab Herceptin, where the outcomes are tremendously different, mainly through alternative funding. So in terms of access and cost, I think we have somehow come across it with some, of course, not 100% great, but the limitations, I think, have been worked on. As just a small comment with regards to HER2 testing and concordance rates of IHC and FISH testing. So under Ministry of Health hospitals, so far we have got 7 hospitals which have reported their concordance rates officially. And these are Sultanah Aminah in 2019, Hospital Serdang in 2019, Putrajaya Hospital 2021, Hospital Selayang in 2021, Hospital Pakar Fatimah Mua in 2021, Ipoh General Hospital 2022, HDA Kuantan 2022. So for all these 7 hospitals which have reported officially their IHC and FISH concordance rates for HER2 testing, we actually do not repeat their IHC or FISH in HKL. All other centers, when they come into HKL, so by the way, HKL has got 17 referring hospitals which all are doing mastectomies and breast surgeries. So for the rest of the hospitals, we end up repeating the IHC and we end up repeating the FISH if it is 2+. So if it's IHC 3+ under HKL, then we do not do the FISH. But if upon review, so it's, I think, in my opinion, a lot of extra work because we need to get the tissues out from those respective hospitals. We need to get it reanalyzed in HKL, and then sometimes the FISH comes in. So if there's some pathologists in the crowd who are from other hospitals besides these 7, I think it will be extremely useful if the concordance rates of the HER2, IHC, and FISH are established to cut down the workload and hopefully benefit our patients. That's all from oncology. Thank you.
Thank you so much, Dr. Vaishnavi. So I think due to time constraint, we shall wrap up this session. Yes,
sorry.
Yes.
Sorry, there's one more thing, because I think the whole idea about this connection that now we have across the hospitals is how we're going to actually come up with our MDTs, you know.
Yeah,
And then we know that Dr. Khadijah from Hospital Sungai Buloh, then you don't have the complete set to run an MDT in your hospital. So I wonder if any comments from the HKL group on whether, you know, because I know like this patient, for example, she could have been referred, right, for neoadjuvant therapy. So maybe Khadijah, some comments?
Not sure because, her specimen ended up as a positive from the big specimen. So if we had given her the neoadjuvant, is there any implication later on that she wasn't supposed to have it as neoadjuvant? Dr. Vaishnavi, when you have such discordance, so a patient end up to be a false negative, but we wouldn't have known before we gave the initial treatment for the neoadjuvant. So how do we go about that? What happens later when we find out the surgery is actually a positive?
I think it would be quite catastrophic either way. So if it was positive and we gave her the neoadjuvant trastuzumab, and if it was truly positive, of course, the patient would likely benefit. The response rates are actually pretty good. Most patients will tend to respond. If it was HER2 positive on the initial biopsy, I don't think it will be repeated on the metastatic specimen. So likely the patient will continue with adjuvant anti-HER2 therapies, and that might go on for 6 months under Ministry of Health funding. The cost of the biosimilar is 1,500, which is quite cheap relative to the original, but nevertheless, it's still money, and we might deprive other patients who could have got it if it was actually negative, because there's always a waiting list of patients who are waiting for this drug. So I think either way, either it's over treatment or it's under treatment, and in both ways, not the best. Yeah.
I would just say that in this case as well, I mean, it is recommended after neoadjuvant chemotherapy when you have the excision specimen, if you have residual disease, to repeat the biomarkers. That is a recommendation. So you would have picked up that heterogeneity. You presumably would, you know, if she'd been incredibly lucky, she'd have had a path CR and, you know, that's it, she's done great. But if she'd had residual disease, you know, you would have picked up that ER positivity, that heterogeneity on that residual disease, just as likely as you did on the excision, you know. So I don't think it's a problem starting, I mean, and I don't think it's a problem. I think it's more important to know, you know, is the patient responding to whatever treatment you give them when they're HER2, you know, positive or triple negative. That's much more important.
So, I mean, I'm sorry, I'm always the one who will put the health system into the discussion. So, do you think that a MDT, you know, needed by, let's say, Sungai Buloh would be able to communicate with people in HKL for like a discussion of some of the cases that they may have to refer quite expediently? Do you think that could happen? Like maybe next by...
Prof, I think is if the specimen's been reported to any of the pathologists, you can just hook on to them for them to participate in the MDTs, because for these activities, yeah, we are not let's say lymphomas groups. We although it's been discussed in Hospital Ampang, but our pathologists go there and discuss the cases together with the clinicians. So I don't see that is a border between these hospitals. Even if a university site, yeah, for example, like UM or UKM, we can just call them and come and discuss together. I think with this, our nation now, with all these facilities, yeah, digital facilities, I think we can just hook on. No issue at all, I think.
Yes, it's not going to be a problem at all. But the Zanaria, right?
Yeah. Because I think as a pathologist, as a center of reference, we receive a lot of centers from the whole countries. Even we also receive some reference from the universities or other institutions. So you can, just call us for any discussions or any doubt to the...
Yes. I think even in most hospitals, we do have MDT session with the oncologist. And the oncologist can be in HKL even, because there's now, there's such thing as Zoom.
I think MDT for the Ministry of Health, the MDT is one of the activities which is going on.
It's regular.
Not a very rare occasions lah. even a
So
smaller
for
hospitals.
our center, we need a three-way thing because we need the oncologist from HKL, which is our referral center, and we need the pathologist from either UiTM or Selayang, depending on the cases. But if we are going to do an MDT and discussing mixed number of patients, it will definitely require pathologists from both UiTM and Selayang, isn't it?
I don't think it's going to be a problem. Yeah.
Yeah, like Dr. Salmi said, now is the time, the era of IT, and we are actually practicing it today as well. So parking is so difficult in HKL. Why not just log into Zoom?
Yeah, I would rather to if you want to invite any of us, we would rather to have a VC rather than which we will have to go there. As long as we know what is the cases need to be discussed a day before.
Yeah, that is what COVID-19 teaches us. You know, everything is virtual.
Yeah.
I think roughly, I think being in HKL, you do have a regular MDT. So maybe hospitals like Sungai Buloh could actually share cases, like one case, you know, like when they need to discuss, they could actually present it at the MDT in HKL. I mean, I think as you say, you know, it's borderless now. Yeah.
Yep, I agree with you. I think is the next step for Dr. Khadijah to arrange a regular MDTs and can invite. I mean, Dr. Zana already given a support, Dr. Salmi already given a support, our oncologist. So it's just a matter of starting it.
Okay.
Just give me a call, Khadijah. Yeah.
Okay.
Okay, good to hear that everyone is in line with this plan. Okay, so I think we have already exceeded our time for this session, and I would like to thank all the participants as well as panelists for joining us today, and especially to Prof. Jane Brock for spending your precious time over, probably it's morning now over there, and have a good day.
Thank you very much. It's been an absolute pleasure to be part of this. Thank you.
Thank you so much. Okay, do join us for the next session. We'll send off some flyers of that. Okay, thank you very much. Have a good night.
Bye.